Yes, you can.
Right. Can you see the slide?
Yes, yes.
Right.
Yes, sir.
Right. So today my topic is going to be the anemia and classification. There is a problem with this one because in that topic they have been given a huge list of anemia to cover me today. But I am trying as much as possible to cover from these 2 hours. If not, we will try another day or some many other type of things to cover the rest, right? So when we are talking about the anemia, what is the term anemia or what does anemia mean? Anemia means the reduction of circulating hemoglobin or red cells, right? If it is say simply anemia is, the term anemia is used to describe the reduction or the reduction of circulating hemoglobin or RBC. But to complete that answer, we have to add the reduction is related to the age, sex, as well as the environmental condition of the patient, right? So because of that, if anyone asks from you what is anemia, I just remind that anemia is the condition where the reduction of circulating hemoglobin or RBC according to the age, sex, and the environmental condition. So why this hemoglobin or RBC is going to be reduced or decreased? Normally, this red cell, normally the hemoglobin is going to be composed in red cells. These red cells are going to be in a closed container inside the body. The red cells are going to be put inside a closed container. It is not going to be open to anywhere. So how it can happen, the reduction of this closed container, right? How the reduction of the things inside this closed container is going to be happen. Normally, time to time, it means around 120 days, the red cells are going to be removed from the circulation. Other than that, within these 120 days, how the cells are going to be destroyed or decreased? There should be a mechanism to destroy or decrease. So, one thing is, I told you that after 120 days, the age cells are going to be removed from the circulation. If the age red cells are not going to be replaced, there should be an anemic condition, right? After 120 days, some amount of red cells are going to be evacuated or removed from the circulation. The removed ones should be replaced from the production area. If the production area is not going to be work properly, the replacement is not going to be occur properly because of that anemia can be occur. The second thing is someone has to be stolen the red cells. Someone has to be stolen or pass the red cells before 120 days. It means this closed container has to be injured in a place. Because of that, leakage of the red cells are going to be occur. Because of that, the amount of red cells are going to be lower in the circulation, which will be lead to anemia. The first one is due to the production errors, the anemia can be occur because the replacement of the age red cells are not going to be happen. Because of that, the circulating red cells are going to be decreased. The second one is there is a leak in this closed container or in the circulation, there is a leak. Suppose there is a blood loss due to an injury, due to a accident or something, due to maybe bleeding from somewhere. There is a leakage of this closed container. Because of that, normal amount of red cells are going to be replaced, but excess amount of red cells are going to be evacuated from the circulation. It may lead to anemia. The third one is inside the bottle or inside this closed container, some cells are going to be get destroyed. Right? Sometimes the cells inside the circulation could be destroyed. What is going to be happen? Normal amount of cells are going to be produced and replace the circulation, but the cells are going to be destroyed before their maturation, before they are going to be spend their complete lifespan, 120 days. Sometimes the cells are going to be destroyed inside the circulation. That is hemolysis or inside the system. So there are three mechanisms which may be lead to anemia. First one is production defect. The second one is increased destruction. Third one is the blood loss. Yes.
Tanjima,
Oh.
in chat box, some people ask why they are not moving. Are you already
No,
moving on?
not. Still, I am not going to be move the slides. Right? Still, I am in the first slide, right? Right. So I am just describing what is the anemia and which can be anemia lead. So anemia could be occur due to three things. The first one is the production defect, and the second one is the reduction of circulating hemoglobin of RBC than the normal range according to the age, sex, and the environment is known as anemia. The mechanism of anemia can be occur due to the diminished production or the reduce of the production. It is going to be named as erythropoietic anemia. The second one is blood loss, where I mentioned there is a leak in this system, which may be lead to anemia. Third one is the increased hemolysis, that is going to be named as hemolytic anemia. These are the three main mechanisms which may be occur, which may be leads to anemia, right? So the anemia can be classified in different ways. So if you are going to be refer different books, those books are going to be classify anemia in different ways. Most of the times we are keen, or most of the time we can see morphological classification of anemia. Most of the time we can see morphological classification of anemia. It means the anemia like microcytic, macrocytic, normochromic, hypochromic, and hyperchromic. Likewise, the morphological classification is there. And the second classification is the etiological classification. Sometimes the anemia classify according to the cause. One thing is hemolytic anemia, right? Hemolytic anemia is going to be classified according to the etiology, right? Due to the cause, according to the cause, sometimes we can classify the anemia. Other than that, the pathophysiological classification also available, where it is not going to be used much. The pathophysiological classification is not going to be used much. The main two classification are going to be morphological classification and etiological classification. Out of that, we are going to be talk mainly about the morphological classification. The morphological classification, there are three main types of anemia can be seen. First one is the macrocytic anemia, which I have been mentioned on the last day, where the cells are going to be bigger than the normal cells, where the red cell volume or the MCV is going to be over 102 femtoliters. At that time, it may be either hypochromic or normochromic. The macrocytic anemia could be either hypochromic or normochromic. Out of this also, the most prominent things are going to be hyperchromic macrocytic anemia. The second one is the normocytic anemias. The cells are going to be normal in size. The cells are going to be normal in size, but either they may be hypochromic or normochromic. Out of these, most of the time, the normocytic normochromic anemias are the prominent. Sorry, it is very rare conditions we can see the hypochromic, normocytic hypochromic anemias. Then the third one is the most prominent one, or the most leading anemias that could be seen in Sri Lanka. That is microcytic anemia, where the cells are going to be smaller than the normal size. The MCV is going to be less than 78 femtoliters. The MCV is going to be less than 78 femtoliters. Most of these cells are going to be hypochromic, right? Most of times these cells are going to be hypochromic. Sometimes the normochromic cells can be seen, but very rare. So three major types of morphological classification we can see. The first one is hypochromic macrocytic anemias, then the normocytic normochromic anemias, then the hypochromic microcytic anemia. Right? Out of these, we'll take the first one. The first one is the hypochromic microcytic anemia. Right? The first one is the hypochromic microcytic anemia. So before I move on to that hypochromic microcytic anemia, let me show you a small picture about the hemoglobin molecule. This red cell is going to be fully filled with hemoglobin, right? So you know that's why it is going to be die within 120 days, because all the enzymes and the other things in this red cell is going to be much only up to 120 days. After that, the red cell is going to be get destroyed in the liver and spleen, right? This red cell is fully packed with the reds. Most of the areas are going to be packed with the red cells. According to the packing condition, the red cell is going to be show a biconcave shape. Right? If we take one molecule of hemoglobin, it is going to be look like this. It is composed of iron and protein molecules. It is composed of 4 iron molecule or heme molecule and 4 protein or the globin molecules. Out of these 4 globin molecules, 2 is going to be beta globin and the other 2 is going to be alpha globin. 2 is going to be beta globin and the other 2 is going to be alpha globin. Right. Suppose now the cell is going to be normal in size due to the presence of the cell is going to be the red cell is going to be normal in size due to the presence of hemoglobin. I told you that normally average about 27 to 32 picogram of hemoglobin should be present in a cell. Average size is 27 to 32 picogram, right? Suppose if the amount of hemoglobin going to be less in the cells, if the amount of hemoglobin going to be present in the red cells are going to be lesser than 27, right? Right. If we are going to a shop, we are taking a bag to bring sufficient amount of goods, right? Right. If we are going to get more goods, we have to take a big bag. But if we are going to bring the small amount of goods, we have to take a small bag. Likewise, if the amount of hemoglobin is going to be present inside the cell lesser than the normal, obviously the red cells are going to be get smaller. If the amount of hemoglobin going to be present inside the red cells are going to be get lesser than the normal, the cells are going to be get smaller, right? So what can be lead to the reduction of this hemoglobin? Right. According to this picture, the hemoglobin is going to be made up with protein and iron. If in any instance, if the iron is going to be reduced in the patient body, it may be lead to the production of low amount of hemoglobin. Ultimately, the hemoglobin level present in the red cells are going to be get low. Because of that, the red cells are going to be get smaller and the percent of hemoglobin is going to be get low. At that time, we name that cell as a microcytic cells. These microcytic cells born because the lack of iron. Because of that, that condition is going to be named as iron deficiency anemia. Due to the deficiency of iron, the red cell is going to be get smaller and the presence of hemoglobin is going to be get lesser. Because of that, we name that condition as iron deficiency anemia. Likewise, if the globin chains are going to be get absent, the same results can be occur. Right? Here, two components are involved in the production of hemoglobin. If one component is going to be get less, the production of hemoglobin is going to be less. Because of that, the red cell ultimately going to be get smaller. If the globin molecules are going to be get low, what is going to be happen? The same results. If globin chains are going to be get low, it may be lead to microcytic anemia. Such conditions are going to be named as thalassemia or hemoglobinopathies. If the abnormality is going to be present with the defects of the globin chains, that may be lead to condition named as thalassemia and hemoglobinopathy. On the other way, sometimes due to the increased amount of iron, the red cell can be get smaller. Why is there? Why is that? Due to the accumulation of iron, the cells are going to be identified as toxic cells. Because of that, within the bone marrow, these cells are going to be get destroyed. Due to the increased amount of iron, the red cells are going to be identified as toxic cells. Because of that, within the cells, these red cells are going to be get destroyed. Now, what is going to be happen? They produce the red cells, but they are going to be get destroyed within the bone marrow. Because of that, the bone marrow is going to be produce red cells with the remaining amount of iron and globin. හදන එක කැඩෙනවා. මේකෙන්ද මොකද කරන්නේ? Body produce some amount of cells which are going to get smaller, and some cells are going to be even present with the iron granules. It may be lead to a condition known as sideroblastic anemia. Because of that, we have to talk about 4 types of hypochromic microcytic anemia, right? In this microcytic anemia, as I mentioned earlier, the cells are going to be small in size. Hemoglobin level is going to be decreased. Because the hemoglobin level is going to be decreased, the PCVO HCT is going to be decreased. MC is going to be less than 78 femtoliter. Sometimes in iron deficiency anemic condition, it may be lower than 68 femtoliter. Most of the time, these cells are hypochromic. They are having low amount of hemoglobin inside the food. There are 4 types of hypochromic microcytic anemia could be observed. The first one is iron deficiency anemia. The second one is thalassemia. And third one is the hemoglobinopathies. There is a difference between the thalassemia and hemoglobinopathies. That's why it has been categorized as a separate one. The fourth one is the sideroblastic anemia. Out of that, the first one which I have been taught is the iron deficiency anemia. What is going to be happen in iron deficiency anemia? Due to the decreased amount of body iron, due to the decreased amount of body iron, this iron deficiency anemia is going to be occur. What may be leads to the deficiency of iron? So what are the cause for the deficiency of iron? It may be poor dietary intake. Some people are not going to be having sufficient amount of iron. It may be pregnancy, increased demand of iron. It may be parasitic infection, such as hookworm infection, which may be destroy the red cells and remove the iron and hemoglobin from the body. It may be a blood loss in some cases, right? So prolonged bleeding inside the body maybe lead to the decrease or the reduction of the body iron. So in this one, how we are going to diagnose the patient with the iron deficiency anemia? What we have to do, we do the full blood count. we can see in the full blood count hemoglobin level is going to be less. We can see the low amount of hemoglobin level, and MC is going to be less than 75 femtoliter. As I mentioned earlier, in severe iron deficiency anemia, it is going to be less than 68 femtoliter. Third one is the MCH. It is going to be less than 27. MCH is going to be less than 27. MCHC is going to be less than 32 gram per deciliter. So how we can diagnose? If you observe these parameters are going to be low, HB and hematological indices are going to be decreased, it may be iron deficiency or any other condition. So what we have to do, we have to draw blood film and observe the blood film. In the blood film, you can see there are huge anisopoikilocytosis. It means you can see different size of cells, different shape of cells with low amount of hemoglobin. Anisopoikilocytosis, different size and shape with hypochromasia. You can see pencil cells, fragmented RBC. Likewise, different type of cells could be observed in the blood picture, right? So what is going to be happen in this situation? Most of the time, the clinicians are going to be treat the patient with iron, right? They are not going to be go further. Blindly, they treat the patient with iron. If the patient is going to be recover with the iron treatment, they diagnose that the patient is going to be having the iron deficiency anemia. If not only, if the patient is not going to be respond to the treatment only, they go further test and see which type of disease the patient is going to be having. So if you are going to be go further, we can do the bone marrow aspiration. Actually, in the diagnosis of iron deficiency anemia, we are not going to be done the bone marrow. In the diagnosis of anemia, we are not going to be done the bone marrow aspiration. But if suddenly we aspirate the bone marrow of a patient with iron deficiency anemia, we can see the absence of iron stores in the patient bone marrow. We can see the absence of bone marrow iron stores in the iron deficiency anemic person. So if we draw the bone marrow and stain with the Prussian blue stain or the iron stain, the blue color granules are not going to be seen in that patient. It's going to be low or absent, right? If it is a severe case, the bone marrow stores are going to be absent. Then we are talking about serum iron, definitely low, because due to the lack of iron, the patient is going to be having the iron deficiency anemia. The next one is the total iron binding capacity. So total iron binding capacity, in another words, it is serum transferrin. The protein which carries the iron is going to be named as the transferrin. The total iron binding capacity represent the serum transferrin level. So what is going to be happen here? Due to the lack of iron, the free transferrins are going to be increased. The amount of saturated transferrins are going to be get low. Because of that, TIBC as well as or in another way, the transferrin is going to be get increased. Serum ferritin is the another form of iron in the body. If the body iron is going to be low, the serum ferritin ultimately is going to be get decreased. The next test is serum transferrin receptors. The same way where the serum transferrin receptors are going to be get increased. Because the lack of iron, circulating iron, the serum transferrin receptors are going to be get increased. These tests, transferrin, ferritin, transferrin receptors, has to be done in immunoassays, but in basic diagnosis, we are not going to be done these, but in the specific case of the diagnosis, we have to perform these tests to come on to a conclusion. The last one is the exact cause. We have to last one, we have to know the exact cause. Suppose you diagnose a patient with iron deficiency anemia as iron deficiency, blindly you treat with the iron treatment, the patient is going to be recovered with this treatment. But after another 3 or 5 months, the patient is come again and say the same, complain the same phenomenon and complain the same very and say this is the things that which I have been happen. I have been having. At that time, you have to find out the exact cause. At that time, you have to find out the exact cause. To find out the exact cause, you have to do the parasitological investigation to investigate whether the patient is having infection, parasitic infection. You have to perform, or we have to ask the patient dietary history, and you have to perform or examine for the patient for the external bleeding or internal bleeding or chronic bleeding. So this is the right. So if you observe a blood picture of a patient with iron deficiency anemia, it is going to be look like this, right? It has the hypochromic microcytic cells, and it has elongated cells, which is going to be named as pencil cells, and different type of cells, the teardrop cells, sometimes occasionally target cells, right, can be seen, and the hypochromic microcytic cells, the fragment cells are the most prominent things, right? Okay. Before I move on to the next one, any question regarding the iron deficiency anemia?
Hello. Hello.
Yes.
Regarding TIBC, can you briefly describe how do we determine TIBC in practical approach? This is not actually,
Right.
yes,
Okay.
particular formula is there. Could you describe how it is
Right.
determined?
So exactly, I cannot tell say the formula, but I can briefly describe how you are going to determine the total iron binding capacity, right?
Mm.
So what we are going to do, we may take a patient sample and directly measure the iron present in that patient serum sample, right? First, we determine the amount of iron present in the patient sample, and then we take the patient plus serum and add excess amount of iron to the serum,
Mm.
right? We add excess amount of iron to the serum and remove the, after a certain time of period, remove the remaining excess iron.
Mm.
Right? I think you got the point, right?
Yes.
First we determine the iron, then we add excess amount of iron, then remove the retained excess iron.
Mm.
Now the bodies, now the sample is having the total iron which has been bound to the transparent. So then we estimate that iron and reduce the first amount of iron or the earlier amount of iron, and it is going to be given as the TIBC or the total iron binding capacity. Sorry, the total one is going to be give the total iron binding capacity, and the reduced one is going to be going to give the uniron bounding capacity. Right?
Right. Another question regarding iron deficiency and hereditary elliptocytosis. So how
Sorry,
it
I
vary?
can't hear you. Can you increase much of
Yes.
your volume?
Now, in case of iron deficiency anemia, we can see such blood film as you saw, right?
Yes.
Here.
Yes.
So in case of hereditary elliptocytosis, even we can see elliptocytes present in.
Elliptocytes, right?
Yes. So how do we differentiate according to the morphological
right.
features of that?
So it is going to be depend on the percentage of elliptocytes, hereditary elliptocytes and hereditary spherocytosis. It is going to be depend upon the percentage, right? Sometime in iron deficiency anemia, minor amount of elliptocytes can be seen, but here I can't see any type of elliptocytes.
Yes, actually.
But in some cases, maybe we are diagnosing the patient with hereditary elliptocytosis where it is going to be more than 20 to 30%. If the patient is having more than 20 to 30% of elliptocytes in the blood film, we suspect that the patient is having hereditary elliptocytosis.
Supportive investigation, what are supportive
Pyruvate
investigation?
kinase estimation.
Right. Thank you.
Right. Please increase the sound. Is it that? Can't you hear? Is it okay now? Can you hear me? Okay.
Yes.
Right. So shall I move to the next one? Right. The next one is thalassemia. When we are talking about the thalassemia, I told you for the production of hemoglobin, we want heme or iron as well as globin. So in the production of hemoglobin, two types of globins are going to be involved. One is going to be named as alpha globin, and the other one is going to be named as beta globin. Right. As I mentioned earlier, if any type of globin chains are going to be decreased, if any type of globin chains are going to be diminished, the production, it may be lead to a condition known as thalassemia. Right. So you may know that there are two types of thalassemia. If beta globin production is going to be decreased, it is going to be lead beta thalassemia. If the alpha globin is going to be reduced, if the alpha globin production is going to be get reduced, it may be lead to alpha thalassemia. But when we are talking about the thalassemia in Sri Lanka, the most prominent one is beta thalassemia. Right? When you are talking about the types of thalassemia in Sri Lanka, the most prominent or the mostly available thalassemia type is beta thalassemia. Right. For the production of beta globin in our genetic materials, two genes are going to be involved. Two allelic genes are going to be involved in the production of beta globin. Right? For the production of beta globin, it is a protein. Two allelic genes are going to be involved. If both these genes are going to be get deleted or diminished, if both of beta genes are going to be get deleted or diminished, the beta
Yes.
globin production is going to be completely stopped.
Sorry for disturbing. We can't
Yes.
see your slides.
So I didn't move it.
All right, sorry.
Right? Okay, I think most of you are going to be familiar with the description with slide, no? But that is not my way. Okay, I'll go with you, right? Right. So thalassemia, this is a genetic disorder which I have been mentioned, right? First listen the description which I am going to be told, describe you, right? So in the production of beta globin, two allelic genes are going to be involved. If these both genes are going to be get deleted, no production of beta globin chains, which may be lead instead of beta globin, any other type of globin is going to be involved in the production of hemoglobin molecule, right? Hemoglobin molecule is going to be produced is 2 alpha and 2 beta globin. If the beta globin is not there, they are going to be look for another type of globin. So what is going to be happen? The hemoglobin molecule is going to be produced along with alpha and gamma globins. Right? The result is the production of fetal hemoglobin. Or it is going to be produced the hemoglobin which are going to be present in our fetal life. What is the problem with these? These fetal hemoglobins are having high affinity to oxygen. High affinity means they are more fond of oxygen. They take oxygen, right? But in another way, they are not going to be willing to release the oxygen. That is the problem with the fetal hemoglobin, right? So that's why in that situation, the patient is going to be having breathing difficulties and the carrying of their lifespan is going to be get difficult. Because of that, the patient actually the production of the fetal hemoglobin is not going to be up to much level. If they are not going to be produced the fetal hemoglobin, they are not going to be produced the fetal hemoglobin up to the level that normal hemoglobin production. Because of that, the result is going to be the produced small cells. Right? In that situation, the patient has to be transfusion depend. The patient has to be transfused blood time to time. So if we observe the blood film, all right. So one thing is, if the patient is having the both genes affected, no no adult hemoglobin is going to be produced, because of the results is the elevation of the fetal hemoglobin. Suppose if one gene is affected, there are two genes. Out of these two genes, one gene is affected, but one gene is going to be get produced. So what is going to be happen? This is enough for the patient to spend the life. This amount is enough the patient to spend the life in normal condition. But in some conditions, such as the living in high altitudes or climbing mountain, the patient may get difficulties. In such situation, the patient may be having some difficulty, but not apart from that, the patient is not going to be having any problem. They are going to be spend the normal lifespan. But the patient with both gene deleted, they have to be spend. They have to spend the life with transfusion dependent life. They have to be spent. So what is the difference between these two? In both the deleted one, the patient is showing fetal hemoglobin elevation, increased amount of fetal hemoglobin. But in one elevation, the patient is going to be having the HbA2 elevation. Normally we name adult hemoglobin as HbA1, but in one gene delete condition, the patient is having HbA2 elevation. So these two type things are going to be named as, if the both genes are going to be get deleted, it is going to be named as beta thalassemia major. If one gene is going to be get deleted, it is going to be named as beta thalassemia minor. The patient with beta thalassemia minor, they can spend a normal lifespan, but they need to be careful in their marriage. They need to be careful in their marriage. They do not marry another thalassemia minor patient, which may lead to the production of their children as beta thalassemia major patient, right? The patient with beta thalassemia minor, they should not marry another patient with beta thalassemia minor, which may be lead to the production of offspring or their children with beta thalassemia major, right? So if we go to the types, there are two types, alpha thalassemia and beta thalassemia, right? So beta thalassemia also there are two types. One is beta thalassemia major. Because both genes are deleted, we name them as homozygous son. Beta thalassemia minor, one gene is affected, it is going to be named as heterozygous thalassemia. So as I expressed, the beta thalassemia major, two allelic genes responsible. Beta thalassemia major patients are having the both gene deletion or mutated. Hence the production of beta chains are absent. The production of normal adult hemoglobin is altered. Because of that, extramedullary erythropoiesis, ineffective erythropoiesis. You know that normally the production of red cells are going to be occur mainly in bone marrow. Other than the bone marrow, there are the dormant places like liver and spleen where the red cells can be produced. In this situation, what is going to be happen? Liver and spleen come into the action and they are going to be produce the red cell, but those are not going to be effective, named as ineffective erythropoiesis. Due to the diminished production of beta globin, accumulation of alpha chains are there. This has to be mop up or has to be removed. Mopping up is going to be, or removing is by going to be done with the production of fetal hemoglobin, right? So when we come on to the laboratory findings, all these parameters, hemoglobin, MCV, MCH, and MCH is going to be low in beta thalassemia major. And if we move to the blood picture, it is showing marked anisopoikilocytosis. It may be with the pencil cells. The prominent cells are going to be target cells. The blood picture is going to be having a lot of target cells along with the hypochromic microcytic cells. And the other very important thing is, it is having the normoblast. right? Hyperchromic microcytic cells, target cells. Along with the target cells, it is having the norm blast. We have to suspect about the patient is having beta thalassemia major. This is not the confirmatory test. What we have to do, we have to do the hemoglobin electrophoresis to differentiate or to identify which type of hemoglobin is going to be prominent in the patient. Ultimately, if the patient is having beta thalassemia major, it shows fetal hemoglobin band is going to be increased. In the hemoglobin electrophoresis, you can see the fetal hemoglobin band is going to be increased. It can be done by the electrophoresis, so HPLC or the high performance liquid chromatograph, right? Those are the confirmatory tests. But the first one is you have to do the full blood count and all the parameters and the hematological red cell indices are going to be get low. Then do the full blood picture. You can see hyperchromic microcytic cells, target cell, fragmented RBC, norm blast going to be plus. Sometimes the mild amount of reticulocytes can be increased, and other than that, red cell inclusion or alpha chains can be seen. It has to be done with the supravial stain, which I have been mentioned in another day. So demonstration of alpha chains can be done by special stain. Then the confirmatory tests are going to be arrived. This is the picture of the patient with thalassemia. See, a lot of target cells are going to be present, right? And polychromatic cells are there. And normoblast. In this one, it is in a normoblast and target cells. Here it is a normoblast. You can see the normoblast, right? Then special investigation, bone marrow. If you observe the bone marrow, it has active bone marrow where many red cell precursor. Why there should be a lot of many red cell precursor? Because the produced cells are not going to be get effective. Because of that, those cells may get hemolyzed or get lyse, or liver and spleen are going to be get destroy these cells. Because of that, the bone marrow is going to be increase their production. Because of that, the bone marrow is active bone marrow with high amount of cells. HbA2 is normal or increase, slightly increase, but the elevated one is the fetal hemoglobin. If you observe the bone marrow, it is going to be show a lot of bone marrow iron. Why is that? It has enough amount of iron, but lack amount of globin. That's why the bone marrow iron stores are going to be increased. The confirmatory tests are going to be HB electrophoresis and HPLC, right? Then the second one is the beta thalassemia minor. There one gene is affected. So this is done, or the diagnosis is going to be actually done in an accidental situation where we see the patient is having normal amount of hemoglobin. Almost always it is going to be more than 10. Most of the time what we are going to be we are going to be misdiagnose the patient is having the iron deficiency anemia. I told you that earlier. If the patient is having low amount of hemoglobin, the first one what we are going to do, we treat the patient with iron blindly. At the second time, if the patient is not going to be respond to the iron, we think about the other types of disease. But at the first time, you can think about a patient with beta thalassemia minor. It is a very simple clue is there, where I told you that there should be a relationship between the hemoglobin level and RBC count. Whether you do the full blood count manually or the automated analyzer, the hemoglobin level should be 3 times of RBC approximately. But when you come on to the thalassemia minor patient, beta thalassemia minor patient, their hemoglobin level is going to be 10 to 11, around 10 to 11 gram per deciliter. But always, all the time, their RBC count is going to be go more than 5.0. Sometimes it may be even 6.0 into 10 to the power 12 per liter. Right? So if the patient is having 10 hemoglobin, as our patient, the RBC count should be around 3.1 or 3.2. But the patient who is having the beta thalassemia minor, their RBC count is going to be over 5.0, 5.5, 6 point, likewise. So in your full blood count, it shows the patient may be having beta thalassemia minor. So what we have to do, we have to screen the patient for thalassemia trait. So what we are going to do, the confirmatory test. So the blood picture is same as the iron deficiency anemia. It is having the hypochromic microcytic cells, and it is going to be having the pencil cells and the other fragmented cells. Sometime here and there may be 1 or 3 target cells there, and blasts are not going to be present. Very important thing is there. In thalassemia major, we can see the blast, but in beta thalassemia minor, we cannot see the blast because no need of compensation. Bone marrow has not to be produced more and more cells because the patient is having normal white strand. But the confirmatory test is hemoglobin electrophoresis. What we are going to be there, we can see HbA2 is going to be elevated in this patient. Beta thalassemia minor patients are having higher amount of, right? When we are talking about the HB, it is going to be low normal, not normal, it is going to be low normal. MC is going to be a decrease, MGH is going to be decreased, HC is going to be slightly decreased. So HB low normal, MCB low, MCH is low, HC is going to be slightly lower than the normal. Right, the blood picture mild anisocoilocytosis, but in the beta thalassemia major, marked anisocoilocytosis is there. Hypochromic microcytic cells, their target cells may or may not be fragmented RBC there, but no blast. Right, bone marrow normally not done. HbA2 increased, HbF not elevated. Bone marrow is not aspirated, because of that bone marrow iron is not going to be done. HB electrophoresis show abnormality where the HbA2 band is going to be, right? Then we come on to the other type of thalassemia, it is alpha thalassemia. Here is a somewhat complicated one. I told you there are only 2 genes related to the production of beta globin. But once we come on to the alpha globin, there are 4 genes are going to be related to the production of alpha globin. Because of that, if one gene is deleted, it is not going to be give a much problem. We name it as alpha thalassemia minimum effect. If 2 genes are going to be affected, we name it as alpha thalassemia minor. As beta thalassemia minor, it is going to be named as alpha thalassemia minor. If 3 genes are going to be deleted, it is going to be named as HBH disease or beta alpha thalassemia major HBH disease, where 4 beta globin chains are going to be get together and produce the cells. 4 beta globin chains are going to be get together and produce the cells. And the fourth one is alpha thalassemia major HB Bart disease. These patients are not going to be born. Alpha thalassemia major patients, they are not going to be born. If they are going to be born within 1 or 2 hours, or maybe less than 1 day, they are going to be die, because in alpha thalassemia major HB Barts means instead of alpha globin and gamma globin, all the protein molecules are going to be gamma chains. That's why it is going to be named as B bars. Inside the fetus, this is going to be destroyed. Because of that, the baby is going to be get edematous and develop a baby named as hydrophytalis. The baby is going to be look like a water drop. That's why it is going to be named as hydrophytalis. But in Sri Lanka, we are not going to be talk about this. The major one is the alpha thalassemia major and alpha thalassemia minor. So you want to know the way how you can differentiate beta thalassemia major and beta thalassemia minor, and what are the phenomenons that can be present in the blood picture of those, right? Any question before I move on to the next one?
Yes, I have a question regarding beta thalassemia.
Yes.
As you mentioned, we can categorize in both major and minor. as I hear sometimes according to genotypes,
Yes.
right? Beta thalassemia intermedia is also categorized, right?
There is a situation named as beta thalassemia intermedia.
Intermedia,
It is
yes,
very difficult to differentiate.
yes. So mutation quite mimic. That's maybe the reason.
Yeah.
But uh, when we find is something, is it enough to categorize them as minor and major?
No, actually, what is going to be happen? This is a transitional situation where the beta thalassemia intermedia is going to be occur. So, which I want to say, if the patient is having beta thalassemia major, these patients are going to be not having a lifespan up to 10 years, right? So they are going to be transpatient depend. Sometimes maybe, but most of the time their lifespan is limited to up to 10 years, right? If the patient is go beyond that, uh, transmission dependent can be happen. But in some situation, what is going to be happen? The patient with beta thalassemia minor, they spend the normal lifespan. Suddenly, they are going to be move on to a difficult situation. That is the transform one, right? At that time, what is going to be happen? The working gene also going to be get mutated, though something is going to be happen. So at that time, we have to go in deep detection of gene detection of the patient, whether the patient is having beta thalassemia intermediate. But it is very rare condition, right? The prominent one is thalassemia major and minor, but it is there.
This is an additional question. Apart from hematological representation of the conditions, what are the investigations to help to monitor the patient?
Which one?
Beta thalassemia.
Beta thalassemia major one or the minor one?
Both.
Right. So beta thalassemia minor ones, no need to continuous assessment or the things, but the patient has to be educated. Such a disease that you are having, but do not fear. You can live a normal lifespan. But in the patient with the beta thalassemia major, we want to check the patient time to time their hemoglobin level as well as the iron level, because sometimes the iron overload can be occur, which may be shorten the lifespan of the patient. Because the patient is transfusion dependent, it may be for the iron overload. As well as the patient is having the bone deformities. I told you that the bone marrow is going to be having heavy active bone marrow, right? Especially in the infant stage, we know almost all the bones are going to be produced the red cell. Because of that, they are bone deformities such as skull enlargement and edematous of the joint, like things can be happen, and inflammation of liver and spleen, hepatosplenomegaly can be there. We have to monitor those
Right.
in the management of patient.
Thank you.
Right. How HBH disease? Right. HBH and HBF. Okay, I'll go on to the HBH on later of my slide when you are talking about the hemoglobinopathies. But when you are talking about the HBF, what do you want to know about the HBF? Right. HBF is the fetal hemoglobin, which is going to be present in the fetal stage. It is going to be start the develop inside the fetus around 3 to 5 months of the time. And once the baby is going to be born, after about 6 to 1 year of time, the patient fetal hemoglobin is going to be get deteriorate. But even in the adult time, less than 1% of fetal hemoglobin could be there, right? In adult state also, less than 1% of fetal hemoglobin could be there. In beta thalassemia major, actually what is going to be happen? So normally in gamma chains are going to be replaced after 1 year, and the patient is going to be produced the adult hemoglobin with the help of beta globin. If the beta globin production is not there, the hemoglobin persists along with the alpha and the gamma globin as fetal hemoglobin, right? That is the situation of HbA. HbH disease I'll discuss on next two of my slides. The same answer will be given how we can diagnose HbH disease, right? Apart from that, any other questions? Okay, when we come on to the hemoglobinopathies, actually when we are talking about the thalassemia, we talk about the defects of the production of the globin chains. Maybe completely diminish the production or maybe partially diminish the production. But when we come on to the hemoglobinopathies, it says the globin chains are produced normally, but the protein sequence are going to be get abnormal. The globin chains are going to be get produced normally, but the protein or the amino acid sequence are going to be get altered, right? So it may be sometime instead of one protein molecule, any other type of protein molecule can come and join there. But the same thing, the same size of the protein molecule is there. But there is a abnormal protein, abnormal amino acid there, which is not going to be relevant to the appropriate protein molecule. So what is going to be happen? This may be caused to the red cells. So the very popular, the very famous one in the hemoglobinopathies is HbS or the sickle HB, where the glutamic acid is going to be replaced by a valine molecule in beta polypeptide. What is going to be happen? This valine molecule is going to be get closer in low oxygen concentration. Oxygen adu vecha gamma me valine molecules are going to be get together. What is going to be happen when these molecules are going to be get together? Ultimately, the red cell is going to be get shrink to that side. It is look like where we squeeze a ball by hand. අපි බෝලයක් අතෙන් squeeze කරාට පස්සේ එක පැත්තක් එබෙනවා වගේ. Now what is going to be happen? Ultimately, they produce a cell look like a sickle. This is reversible for a time of period. But if the oxygen concentration lowering is going to be get persist, it is irreversible, right? So this irreversible red cell is going to be get removed from the circulation in the liver and spleen. Ultimately, it causes reduction of hemoglobin and the red cell, which may be cause a anemic condition, right? So I told you there are two genes represent the beta production. If both gene is going to be affected, like it is going to be named as homozygous sickle cell anemia. If one gene is going to be affected, it is going to be named as heterozygous sickle cell anemia. There are a lot of investigation to diagnose sickle cell anemia. There are one screen test, sickling test. So where we look for the sickle cell in the reduction of oxygen concentration in a glass slide under the dark field microscope. We see a blood film where we see a drop of blood which is mixed with sodium metabisulfite and covered with the cover slip which is sealed by Vaseline. Where if the cells are going to be having the sickle cell phenomenon, in that environment, they are going to be get sickle, and under the microscope we can see the sickle cell. But the confirmatory test is going to be the hemoglobin electrophoresis, right? The confirmatory test is going to be the hemoglobin electrophoresis. There are about more than 200 abnormal hemoglobin can be seen in the world. More than 200 abnormal hemoglobin can be seen in the world, right? according to the country, the presence of hemoglobin is going to be differ, right? We are talking about the HbS in Sri Lanka and any other countries, and sometimes we are talking about the HbH. We are talking about the HbH in some condition and HbC in some part of world, right? Right, HbS is abnormal one, the thing which I have been mentioned. Alteration in the tertiary structure in low oxygen concentration, Hb molecules close together, result in the sickling of the RBC. It persists more than few minutes, irreversibly sickle and rapidly destroyed. So sickle cell anemia hereditary means gene affected. S gene එක තියෙනවා නම් it is going to be named as sickling gene. Same one, homozygous and heterozygous. If the both gene affected, homozygous. If one gene is affected, it is going to be named as heterozygous, right? Other hemoglobinopathy more than 200. So in Southeast Asia, it is going to be HbE. In West Africa, it is going to be HbC, right? So most of the time, abnormality of the abnormal globin alter the oxygen binding capacity, right? So results in the releasing and binding of insufficient amount of oxygen. ගොඩක් මේවා having the incapability of to the binding to the oxygen. They are having lack of binding to the oxygen. That's why they are not transporting sufficient amount of oxygen to the body requirement, right? Some abnormal cells they are chemically unstable. They lead to hemolysis. Hemoglobin electrophoresis, this is the useful tool in the identification of abnormal hemoglobin. So by performing that, we can determine which type of hemoglobin are there, whether it is HbH, HbC, HbA2, HbA1. So what we want to do, we have to perform always the time patient sample with the control. In the control sample, we know the amount of the hemoglobin and the type of hemoglobin going to be present. Right. Suppose if you want to know the HbH percentage in the patient sample, you have to run a control which is going to be have a HbH and compare the elevation or the decrease of the HbH using that control, right? If the patient band is going to be elevated higher than the control HbH band, we name that the patient is having the HbH. If the patient is having lower number of HbH band than the control, we say actually it may not be lower, more or less equal to the HbH. We say the patient is having normal amount of HbH, right? So that is the way that we are going to be use the HB electrophoresis in the diagnosis. So that is end up with the hemoglobinopathies. Any question regarding that?
I have a question regarding HbS disease, right?
HbH.
So, yes.
Right.
As I hear, there is a technique called supravital stain.
Yeah.
We can determine HbH inclusion resembling as golf
Ball appearance. Yes.
So, could you? I think this is additional thing in case of observation of blood picture.
Yes.
If the HbH disease suspected, we can do even supravital stain to determine whether the HbH inclusion present in the RBC, right? I think you omit the thing. That's why I'm asking.
Last part I can't hear, right? So normally, actually, in sometimes, even in the blood film, we can suspicious about the HbH or gold ball appearance. But if we want to demonstrate, we have to do the supravital stain and look for the gold ball appearance in the blood film, white supravital stain film, right? Right, okay. The last part of the microcytic anemia, it is sideroblastic anemia. where I mentioned due to the increased amount of circulating iron, the ions are going to be accumulated in the normoblast. The normoblasts are the cells which are going to be responsible for the production of red cells, right? The normoblasts are the earlier precursor of the red cells. In this red cell, the iron granules are going to be accumulated. Actually, what we can see, there may be some amount of iron granules in the normoblast, but in sideroblastic anemia, these iron granules are going to be get located around the nucleus. These iron granules are going to be get located around the nucleus and form ring sideroblast. They form ring sideroblast. What is going to be happen? These ring sideroblasts are going to be destroyed within the bone marrow, because the ions are going to be get toxic, as well as ring sideroblasts are going to be get identified as the abnormal cells. Now, what is going to be happen? Red cell precursors are going to be get destroyed there. Because of that, the production of red cells are going to be get low. Ultimately, it is going to be result low amount of red cell in the circulation, along with the low amount of hemoglobin, because the increased destruction inside the bone marrow. Right. Due to the accumulation of iron granules, these iron granules sometimes even can see in the peripheral blood. Right. Even can see in the peripheral blood. So sometimes the sideroblast can be seen in the peripheral blood, because the demand is increased outside the bone marrow. Hence, they secrete the normoblasts to the circulation. Because of that, there may be normoblasts in the circulation. So how we can diagnose this patient? We have to observe the blood film, and at the blood film you can see the sideroblast, and inside the bone marrow you can see the ring sideroblast, right? And also you can demonstrate the iron granules in the red cells. Actually, I can't remember whether it is the Pappenheimer body or something, iron drops. So it can be seen even in the Leishman stain look like bluish black granules, or using the Prussian blue stain, you can demonstrate the iron granules in the red cells, where it is going to be show that the patient is having sideroblastic anemia. Right? These are the four types of microcytic anemia that can be seen. Right? This is the ring sideroblast. These are the sideroid granules going to be present in the around the nucleus. Here, see, ring sideroblast, right? Here the blood film stain with the Prussian blue reaction. You can see the cells stain with the iron granules, right? That is the end of microcytic anemia. Any question regarding that microcytic anemia?
Yes, in case of sideroblastic anemia,
Yes.
uh, porphyrin ring synthesis abnormality should be the main etiology. Is that correct?
Sorry, I didn't go to your correction. Can you
Or
ask it?
porphyrin synthesis
Yes.
abnormality will, yeah,
Maybe.
yeah. Right.
Right.
Thank you.
Please describe the blood picture of sickle cell anemia. Actually, we cannot find out the blood any abnormality of a patient with sickle cell anemia. Right. The blood picture is going to be hyperchromic microcytic cells are there. Normally, the sickle cells are not going to be present in the peripheral circulation in normal situation. The sickle cells are going to be present in the low oxygen tension. So, if anyone asks from you what is the blood picture of a patient with sickle cell anemia, the patient is having hyperchromic microcytic cells. Sometimes the fragmented RBC and other things are going to be there. So that is the appearance of blood picture. So, according to the severity of disease, if it is a homozygous disease, it is having marked anisopoikilocytosis. If it is a heterozygous disease, it is going to be having a mild anisopoikilocytosis. Okay. Right.
Hello.
Yeah.
What is vaso-occlusion regarding clinical representation?
Sorry, occlusion.
Yes, sir. This is case of sickle cell anemia, clinical representation.
Right. In clinical represent, occlusion means like this, right? So I told you the normal red cells are having flexible cytoplasm cell membrane, right? Where they can easily grow in even in the small blood vessel or the capillary. They can move through these capillaries and each and everywhere due to their flexibility. But once due to the low oxygen tension, if the cell is going to be get sickle in shape, those cells cannot be moved through these small capillaries. So at that time, what is going to be happen? They are going to be block the capillaries and the blood vessels. Because of that, the blood flow is not going to be go beyond that, which may be going to be cause the occlusion, and then the patient, that area, particular area is going to be get necrotic and damaged and maybe get black in color. Necrosis is there. That is the result of the occlusion in the sickle cell anemic condition. That is the anemia clinical condition where the patient present with the occlusion and occluded blood vessels or the occluded vessel.
Thank you.
Right. Let's move on to the other part. That is the macrocytic anemia. That is a very small one. So where we can see the cells are going to be bigger than the normal cells. Right. So microcytic anemia is where the microcytic anemia is where we can see the small cells. In macrocytic anemia, it is going to be the cells are going to be get bigger. So suppose now, if we are considering the term, if the cells are going to be bigger, how the anemia is going to be occur, no? Rather than being small, if the cells are going to be get bigger, there should not be anemia. The problem is not there, which I mentioned earlier. This circulation is a closed one, right? We can put only some much of volume. There should be a fixed volume. Now what is going to be happen? Instead of normal size cells, the bigger cells are going to be come into this circulation, where the amount of cells are going to be get lesser, right? Instead of normal number of cells, big cells are going to be get in lower in number. That may be lead to anemic condition. So one thing which I want to say, these macrocytes or the bigger cells are having the appropriate number of hemoglobin molecules. Maybe, right? Maybe less. Most of the time they are in appropriate number because they are not having a problem with the production of hemoglobin. Suppose if you consider that a red cell is going to be having as a number 10 molecules of hemoglobin, normal red cell is having 10 molecules of hemoglobin. Even in macrocyte, it is going to be having 10 molecules. But in the circulation, there are normal cells, 100 cells. 10 into 10, 10 into 100, 1,000 hemoglobin molecules are there. Right? Just think about this in your mind. So in normal patient, in a normal red cell, there are 10 hemoglobin molecule in one normal cells. In a normal person, there are 100 red cells. It means almost 1,000 hemoglobin molecules are going to be present in this patient circulation. When it comes on to the macrocyte, now the cell is going to be having 10 molecules. No problem is there. But rather than being 100 molecules, now the patient is having about 70 red cells. Now the total volume of hemoglobin molecule is 10 into 70, 700. That's why the patient is going to be develop anemia, right? So why is that macrocytic anemia or the macrocytic anemia is going to be happen like on that way? The presence of macrocytes may be due to the megaloblastic changes. Maybe the problem with the production in the red cell precursor. Right? So normally what is going to be happen? The early precursors are bigger than the red cell. The early precursors are bigger than the red cell. In the development process, these cells are going to be condense their nucleus. Right? They condense their nucleus and they reduce their cell volume. And finally, they extrude the nucleus and fill the red cell with the hemoglobin and send it into the circulation. That is the process. But what is going to be happen in the megaloblastic anemia? The bone, the early precursor or the normblast present in the bone marrow is not going to be get condensed. Why is that? For the condensation of this nucleus, we want thiamine. We want thiamine for the condensation of this molecule. For the production of thiamine, vitamin B12 and folic acid is essential. Vitamin B12 and folic acid is essential. Once the patient is having the deficiency in vitamin B12 and folic acid, what is going to be happen? The production of thiamine is going to be get reduced. Because of that, the condensation of the nucleus is going to be not up to the level. Because of that, the result is going to be the production of bigger cells. So if we observe the patient bone marrow, we can see the megaloblastic changes. It means the patient is having large cells rather than the small normblast. The normblasts are going to be get bigger than the normal patient's normblast, right? That's why it is going to be named as megaloblastic anemia, because the bone marrow show the megaloblastic changes, right? So the peripheral blood show here the Howell-Jolly bodies, where we can see the inclusion body DNA, where the DNA materials are going to be in the circulating RBC. Even in the thalassemia, we can see the Howell-Jolly bodies where the clusters of DNA or the accumulation of DNA fragments get together and produce inclusion body known as Howell-Jolly body. It is prominent in megaloblastic anemia than in the thalassemia. But in the thalassemia, even sometimes can be seen, but it is more prominent in the megaloblastic anemia, right? So Howell-Jolly bodies is there, as well as macrocytes area. Actually, which I can say, rather than they are going to be round in shape, macrocytes is the phenomenon one. The phenomenon cell is going to be the macrocytes, and low platelet count and the low white cell count can be seen. The most important phenomenon in this one is the hypersegmented neutrophil. Normally, neutrophils are going to be having the 3 to 5 lobes, but here it is going to be having more than 6. Even in some time, 8 lobes can be seen. Hypersegmented neutrophils are the most phenomenon one, right? So the main factor of the megaloblastic anemia is the vitamin B12 and folic acid deficiency, right? So especially it can be present in the patient with pregnancy, where their demand is in pregnancy, the vitamin B12 and folic acid is much. due to the development of baby. That's why in the pregnancy stage, iron as well as folic acid is given to the pregnant woman, right? So if the patient is not having the sufficient amount of folic acid and vitamin B12, they may be lead to the presence of macrocytes in their circulation, which may be lead to a condition known as megaloblastic anemia, right? When we are talking about the megaloblastic anemia, the good example for the megaloblastic anemia is the pernicious anemia. Pernicious anemia, where the folic acid and the vitamin B12, especially the vitamin B12, is going to be absorbed by the gut in the gut iliac, right? In the gut iliac, there is a protein molecule known as intrinsic factor, right? If the patient is not having intrinsic factor, no absorption of the vitamin B12, and because of that, no production of the thiamine. Because of that, the result of the macrocytes are going to be present in the circulation due to the development of megaloblast, right? So the pernicious anemia may be due to different reasons. Sometimes the patient may be having continuous hot drinks and the other things which may be damage the endothelial of the stomach, can cause this problem. And sometimes due to the immune attack to the gastric mucosa, immune attack which may be lead to the destroy of the gastric mucosa, it may be damage the gastric mucosa, and intrinsic factor is not going to be there, right? Intrinsic factor is the one which is transport vitamin B12 to the bone marrow and the other place. If the intrinsic factor is not going to be there, no absorption of the vitamin B12 and no production of thiamine, right? So the pernicious anemia where is a good example for megaloblastic anemia. So how we one thing is the macrocytic anemia is the megaloblastic anemia, and the other one is going to be the non-megaloblastic anemia. Sometime in the circulation we can see the bigger cells, but there are no megaloblastic in the bone marrow, no megaloblastic changes in the bone marrow. Sometime we can see macrocyte in the peripheral circulation without megaloblastic changes in the bone marrow. These types are most of the time due to the alcoholic or the liver disease, as well as sometime in the liver diseases. But these non-megaloblastic changes or the non-megaloblastic anemia are very rare condition. By doing the investigation properly, we can differentiate these two. So to differentiate these two, what we have to do, first we have to do the full blood count, right? We'll go on to the test next, right? Right. Macrocytic anemia, presence of abnormal large erythrocyte. They are because of that the bigger of cells, the cell number is going to be less. Because of that, hemoglobin is going to be get low, PC is going to be get low, and MC is going to be more than 102 femtoliter. So it can be two ways. One is megaloblastic anemia and the other one non-megaloblastic anemia. So megaloblastic anemia, presence of macrocytes in the peripheral blood, megaloblastic changes in the bone marrow, and due to thiamine impaired production, and thiamine is going to be produced with the vitamin B12 and folic acid. Peripheral blood smear is going to be show if if you observe a full blood count report where the HB is going to be low and the MC is going to be increased, you can draw a blood film and see this. So you can see alveolar bodies where the pinkish color granule to the eccentric of the cells, which is going to be composed of DNA detached, or the DNA fragments are going to be get accumulated in the cell. These macrocytes, the macrocytes in severe disease circulating megaloblasts. Even severe disease, we can see even the megaloblasts in the circulating system. Thrombocytopenia and leukopenia is there. Hyposegmented neutrophils are there. But remember here, rather than macrocyte, most of the time they are going to be ovalocytes. Oval macrocytes can be seen. Right, see here the megaloblast where the nucleus are not going to be get condensed. Right, if the nucleus is going to be condensed, it should be like this, but here you can see it is not going to be get condensed. This is a hypersegmented neutrophil, and here you can see a lot of see. So I must say that if you are asking, right, you may ask why you are not going to be compare this cell, but see the cytoplasm difference of cytoplasm. This is a hemoglobinized cell. That's why I am talking about, right? This is also a hemoglobinized cells, but the nucleus of this cell is going to be condensed. But here the nucleus is not going to be condensed. That's why they are going to be named as megaloblast. Right? Same thing. Here you can see the macrocyte. This is the normal size of the cells. And here you can see the macrocyte. And the hemoglobinization. The central pallor is somewhat bigger than the normal, because here yellow macrocytes, which I mentioned you, this is the round shape, but here it is going to be oval in shape. Right? This is polychromatic. Right? Macropolychromatic cells. Bigger than normal cells, polychromacy is there. This is the description of pernicious anemia, common example for macrocytic anemia. This is due to malabsorption of vitamin B12, lack of intrinsic factor in the gastric juice, due to the autoimmune attack of the gastric mucosa, which leads to the gastric atrophy, death of the gastric mucosa, production of antibodies against the intrinsic factor necessary for the transportation of vitamin B12, right? That's why if the intrinsic factor is not going to be there, it may be lead to megaloblastic anemia, right? So special investigation. If you observe the thing, you have to, if you want to go further, as in the iron deficiency anemia, we blindly give the patient vitamin B12 and folic acid. If the patient is not going to be respond to this, what we are going to be do, we can do the serum vitamin B12 as a serum folate test. We can see whether the patient is having sufficient amount of vitamin B12 and folate. As well as we can see RBC folate and retic count to check whether the patient is having high number of retic count. Aspirate the bone marrow and look for the megaloblast. Then radioactive vitamin B12 absorption for RAT. This is due for to check whether the patient is having the intrinsic factor defect. We administrate the patient vitamin B12, which are going to be radioactive. After a certain time of period, if it is not going to be present in the body circulation or the body, it means the patient is having lack of the absorption of vitamin B12. That's why we are going to be do the radioactive vitamin B12 absorption in the case of pernicious anemia. Then biopsy of the bowel to check whether the gastric mucosa is damaged or whether it is going to be atrophic or whether the gastric mucosa is going to be normal. We have to do the bowel biopsy investigation, right? Then we come on to the non-megaloblastic anemia, macrocytes in the peripheral blood. Now megaloblastic changes. There are two types. One is with the high reticulocyte count. It is due to probably due to the hemolytic anemia, right? One is the low retic count. It is due to the probably due to the liver disease, right? So the clue of this, the diagnosis of macrocytic anemia, you observe the full blood count and you see the macrocyte, the MCV is going to be get increased, and then you draw the blood film and observe. You can see the yellow macrocytes and the other things in the blood picture, as well as if you can see the circulating megaloblast, definitely it is going to be megaloblastic anemia due to vitamin B12 and folic deficiency. You have to find out the exact cause by doing the special investigation. If you are not going to be see those type of yellow macrocytes and the other things, you can just simply do a reticulocyte count, right? If the reticulocyte count is high, you can suspect about hemolytic condition and investigate for hemolytic anemia. If the reticulocyte count is low, probably the patient may be having liver disease, or maybe patient is having the alcoholism, right? That is the way that we are going to diagnose the macrocytic anemia. Right. Howell jelly bodies in thalassemia, please describe. That is where, right. Howell jelly bodies is I told you that DNA gathering. Right. DNA gathering, right? So DNA gathering could be occur in the even in the thalassemia, because there is the impaired DNA problem, or the I told you that production of beta globins are going to be due to the abnormal gene. It means there is an abnormality in the DNA. So this DNA may be not fully condensed and may be accumulated in the development of RBC, which may be present the Howell jelly bodies in the Howell jelly bodies in the thalassemia also. Actually, it is can be present in the thalassemia major rather than thalassemia minor. Then one is asking what about the RDW? I think he is asking about the RDW of the macrocytic anemias. In megaloblastic anemia, according to the severity, RDW is going to be changed. If it is going to be severe megaloblastic anemia, if it is going to be almost all the macrocytes are going to be there, the RDW is going to be in one range, in the higher range, in a normal range. But if the patient is having the dimorphism, again the RDW is going to be get differ. It is going to be spread out in a wide range of area. Right. So that is the end of macrocytic anemia. I think I have another about 20 minutes. What we can discuss the other part. Or any question before I move on to the other part?
Schilling's test. I need to know about Schilling's test.
Schilling's test for what?
Pernicious anemia.
Yes. Actually, the method is I can't remember what is the Schilling's test, but it is a diagnostic test. But the most common tests are the things which I have been given. The modern tests are the radioactive label absorption test, which may be directly indicate the absorption problem is there. Danushka, I think you asked the question, no?
Yes. Thank you then. Shall I move on to the next one? Okay.
Right. The other one is the nomocytic anemia, right? Nomocytic anemia means here the red cells are going to be get normal, right? So before I go on to the nomocytic, right? In the nomocytic anemia, we have to talk about two conditions. One is the hemolytic anemia, and the other one is going to be the aplastic anemia, right? So when we come on to the hemolytic anemia, right? So why the hemolytic anemia is there? Because the increased destruction or the increased hemolysis of the red cell before 120 days, right? We know the lifespan of the red cells are going to be 120 days, but before 120 days, these red cells are going to be get destroyed or lyse, which may be ultimately lead to an anemic condition known as hemolytic anemia. Right. Most of the time, the bone marrow try to compensate this anemia. Due to the trying of compensation, we can see the increased number of reticulocytes in the peripheral circulation. But if the destruction is going to be more and more, it is not going to be compensate, we can see higher number of reticulocyte count, and the anemia are going to be get persist in the patient circulation. Right? If we are talking about the hemolysis, there are two types of hemolysis can be seen in a patient. One is going to be extravascular hemolysis. Right. One is going to be asked, explain about the methemoglobin reduction test or Brewer's test. Right. I'll briefly tell it in this one. Right. It is going to be lying the hemolytic anemia. I'll explain it to you. Right. Right. When you are talking about the hemolysis, there are two types of hemolysis. One is extravascular hemolysis. Other one is going to be intravascular hemolysis. The normal hemolysis is this extravascular hemolysis. Once the red cells are going to be get age, or when they spend their lifespan of 120 days, they go to the liver and as well as to the spleen, and inside the liver, spleen, or the liver or the spleen, macrophage take these red cells, and it is going to be break down into their raw materials, heme and propyrin, right? Propyrin means the raw material of the hemoglobin production. The heme part, iron is going to the transferrin and they go to the iron pool, and the globin is going to be divided into the amino acid, go to the amino acid pool. The protopropyrin is going to be developed to the bilirubin and then conjugate, and through the liver it come onto the gut. Through the gut, it pass out as tocopilinogen. Some amount is going to be reabsorbed, and reabsorb some amount are going to be go through the kidney and pass as urobilino. Suppose your extravascular hemolysis is increased. This is the normal mechanism. Suppose your extravascular hemolysis, sometime there may be a cell which has been coated with the foreign body. Red cell may be coated with the foreign body. While it is going to be travel via liver, it is going to be trapped with the macrophage and break down. Suppose you are having lot of number of contaminated red cell, they are going to be lies inside the liver, or the extravascular hemolysis is going to be increased. Due to that, circulating bilirubin is going to be increased, and stocobilinogen could be increased, and urobilinogen could be increased. But remember, there are any other pathophysiological condition which you have to talk in the biochemistry. I am not going to be talk about that. There may be blockage in the liver, and there may be some problem. Maybe we simply say this as a jaundice. It may be hepatic, pre-hepatic, or post-hepatic, right? I am not going to be talk about that. But if the extravascular hemolysis is going to be increased, what may be the outcome or what may be the outcome of the investigation, where the bilirubin can be increased, tocopilinogen can be increased, and urobilinogen can be increased, right? Keep it in your mind. Then the other one is the intravascular hemolysis. It is a very rare situation. Sometime in the travel of red cell in the circulation, Anaemia hapila, sometime 1 or 2, 3, or 2, 4, 3, 2 to 3 cells can be hemolyzed. At that time, what is going to be happen? This hemoglobin is going to be absorbed to the kidney with a molecule named as haptoglobin. With a molecule named as haptoglobin, absorbed to the kidney, and then break down it, and it is not going to be through filter through this one. Sometime if the haptoglobin is going to be saturated, it is going to be bind with the albumin and circulate with methemalbumin, right? Hemoglobin breakdown, it is going to be removed by the haptoglobin, then to the liver, and this process is going to be occurred. But if the haptoglobin is going to be saturated, or the breakdown is increased than the normal, it is going to be bind with the albumin and circulate as methemalbumin in excess intravascular hemolysis. Or it may be go to the kidney and filter as hemoglobin, and sometimes when it is going to be passed with the hemoglobin, pass as the hemoglobin, hemosiderin also can be seen in the urine. So hemosiderin urea means we can see the iron granules in the urine epithelial cells, right? It is going to be okay in the intravascular hemolysis, right? Suppose the patient is having intravascular hemolysis, what could be the outcome? They may be having methylmalbumin in the circulation in a elevated amount, and the patient is having hemoglobin urea as well as hemosiderin urea, right? When you are talking about the hemolytic anemia, there are two types of classification. One is site of the defect, and the other one is the site of hemolysis, right? Site of the defect means when you are considering the red cell, the defect may be within the cell. Maybe the problem with the membrane, maybe the problem with the hemoglobin molecules, maybe the problem with the enzyme inside the cell. Maybe the problem with the outside. If it is in the inside, we name them as intracorpuscular hemolytic anemia, right? It may be membrane defects such as hereditary spherocytosis, hereditary lymphocytosis. It may be metabolism defects such as G6PD deficiency or pyruvate kinase deficiency. It may be problem with the hemoglobin such as thalassemia and hemoglobinopathies, right? Membrane defect. This is related to cell. Problem with the cell. Metabolism. Inside the cell enzymes are there. And hemoglobin inside the cell, hemoglobin are there, right? So when we come on to the membrane defect, it is going to be hereditary spherocytosis or hereditary erythrocytosis, right? The prominent one is hereditary spherocytosis, where there is a problem with the membrane. Once the problem is there, actually protein molecule problem in the membrane, what is going to be happen? This defect area is going to be phagocytosed by the macrophages inside the liver. Not the whole cell is going to be engulfed. The part is going to be get removed. Due to that, the result is the spherocyte, right? That is membrane defect. In the similar way, the elliptocytes are going to be occur due to the membrane defect, right? These two is going to be differ. One is going to be the abnormality in the vertical reaction of the cell membrane. Other one is going to be in the horizontal reaction of the cell membrane, right? So if I go deep, these two are going to be related to the ankyrin and spectrin protein problem, right? No need to know it, right? Just to know. Actually, you want to know, but not in this type, right? So just I told you, it is in that ankyrin or spectrin problem, right? According to the problem, it may be a hereditary spherocytosis or hereditary erythrocytosis, right? So what we can do there, these cells are going to be right. If it is hereditary spherocytosis, it is not going to be destroyed. Either the part is going to be get removed. Then the second one is metabolism defect, G6PD. You know that G6PD enzyme is going to be involved in the glycolysis pathway. So if in the glycolysis pathway, G6PD is the essential enzyme for the glycolysis. If the glycolysis is not going to be there, what is going to be happen? Accumulation of the byproducts are going to be there, which can be reduced hemoglobin into methemoglobin, right? So here in the glycolysis, oxidation reduction is there, right? G6PD enzyme is necessary. So I deeply tell this because one person asked about this. So G6PD enzyme reverse that oxidation to the reduced stage, right? So if this oxidation is not going to be reversed, what is going to be happen inside the red cell? Hemoglobin is going to be converted into methemoglobin, right? So that one is going to be used in our the that one is going to be taken into our advantage, and we develop Brewer's test as methemoglobin reduction test, right? So outside the body, what we are going to do, we convert hemoglobin into methemoglobin using methylene blue, right? So if the patient is having D6PD enzyme, it is going to be again converted into hemoglobin and give a red color. If the patient is not going to have the G6PD enzyme, the brown color methemoglobin is going to be persist, and we identify the patient is going to be have the G6PD deficiency patient, right? So there is the argument between this one, whether G6PD, whether Brewer's test is a confirmatory test or the screening test. But actually, I mean G6PD deficiency test or the methemoglobin reduction test is going to be used as a screening test. The ideal one to confirm the G6PD deficiency or pyruvate kinase deficiency or the estimation of enzyme G6PD or pyruvate kinase, right? Then site of effect, it may be intracorpuscular or extracorpuscular, outside the cell. It may be immune conditions such as autoantibody, warm antibody or allo antibody, warm antibody or cold antibody. Warm antibody means they are going to be react at 37 degrees. Cold antibody, they are going to be react at cold temperatures such as plus 422 degrees centigrade. And the alloy antibody means antibody which comes from others, such as hemolytic transfusion reaction. These transfusion reaction, they may be developed antibody, and HDN, hemolytic disease of the newborn. Allografts, it means the grafting of the patient some part of the body. Due to that, antibodies could be developed. And other one, drugs. Sometimes the patient develop antibody against drugs. Those antibodies can be destroy the cell. That's why it's going to be named as alloantibody, right? This is the two type which we can classify according site of defect. Cell එක consider කළා cell එක ඇතුළේද පිටද කියලා intracorpuscular extracorpuscular කියලා හරි කරනවා. ඊට පස්සේ extracorpuscular non-amine ones such as toxic infection, malaria, clostridium infection, ඊළඟට chemical physical agent, ඊළඟට march hemoglobin urea, the army person, some people you know that when they are marching they may pass red color urine. So why is that? Due to the feet touch the floor long time, their red cells are going to be get lyse, and if they pass red color or the hemoglobin with the urine or as hemoglobin urea, it is going to be named as march hemoglobin urea. Then according to site of hemolysis, as I mentioned earlier, it may be intravascular hemolysis or maybe extravascular hemolysis. Intravascular hemolysis means traumatic prosthetic valves march hemoglobin urea. I told you that just now, the march hemoglobin urea, due to the pressure of the feet, the red cells are going to be get lyse inside the blood vessel. As I mentioned earlier, if the hemolysis is going to be increased inside the blood vessel, there may be passage of hemoglobin through urine. So we can see that the march hemoglobin urea. Then prosthetic valve. Sometimes the people may be having artificial valve in their blood vessels. When the cells are not going to travel through these valves, these artificial valves are not going to be much flexible as our natural valves. While they are going to be passed through this prosthetic valve, red cells can be damaged and lyse is going to be increased. Then the G6PD deficiency, enzyme deficiency, due to the oxidation, even in the circulation, these cells can be destroyed, and the result is going to be hemoglobin present in the circulation, which may be passed with the urine. Then immune hemolysis, ABO, right? So ABO transfusion incompatibility. You know that if the blood group is going to be unmatched and transfuse the blood, at the point the patient is going to be hemolyzed. Suppose to a patient in blood group A, we are going to be given the blood group we are going to transfuse the blood with blood group B. The patient is having anti-B, because of that the cells are going to be lysed in the circulation, and that is going to be intravascular hemolysis. Paroxysmal nocturnal hemoglobinuria. At the night time, due to the acidifying of the circulation, due to the membrane defect, the cells are going to be get lies inside the circulation, that is paroxysmal nocturnal hemoglobinuria. So we can demonstrate it by Ham's test. Then infections such as Clostridium velsai and Plasmodium and malaria. Then the other one is extravascular hemolysis. Extravascular hemolysis, autoimmune, such as the hereditary spherocytosis, HE, or the other things. This is going to be occur like this way. When the foreign bodies are going to be get attached to the red cells, while they are going to be travel through the liver and spleen, that part is going to be get removed. That may be cause hemolysis. So the examples for that is warm antibody, hereditary spherocytosis, thalassemia, and other type of liver disease and pyruvate kinase deficiency. Right. To diagnose of hemolytic anemia, you have to observe hemolysis clinically. Right. Before you go on to a diagnosis, you have to observe hemolysis. Then you want to know which type, whether it is intravascular hemolysis or extravascular hemolysis. Then you have to come on to a conclusion to check exactly cause. What is the cause for this hemolysis, right? So test for the hemolysis, full blood count you have to done, and ultimately hemoglobin is going to be low. Then observe the blood picture. You can see the fragmented RBCs and different sizes of red cells. Then reticulocyte count. So most of the time reticulocyte could be increased due to the sign of the compensation of anemia. And other than that, biochemical investigation. By performing the biochemical investigation, you can come on to a conclusion whether the patient is having an intravascular hemolysis or extravascular hemolysis, right? The final one is the bone marrow failure. So that is bone marrow is going to be having a problem of the production of cells, right? Bone marrow failure is bone marrow is going to be having the production problem of the cells. It may be due to any other cause. Sometimes the patient is having a cancer on the bone marrow. Sometimes the bone marrow could be present with the fibrous tissue or the fibrosis. At that time, the patient is having the production of red cells are going to be reduced. But think of this, in this time, there is no problem with the red cell production. There are no place to produce the cell. Because of that, they are going to be produced normal cells, but low number of cells. Right? They are having all the things to produce the cells, but no space. Because of that, they are going to be produced low number of cells, but they are going to be normal in size. That's why it is going to be having a normocytic normochromic anemia. Normal size and normal hemoglobinized cells, but the number of cells are going to be low. Right? Bone marrow produced low number of mature cells rather than producing abnormal cells with shortened lifespan. These cells are going to be spend their lifespan normal, right? So it can be present in two ways. One is going to be pancytopenia. Sometimes all three cell lines can be affected. And the other one is going to be single cytopenia. Sometimes it may be only one cell line is going to be affected. Rare condition. But the most common one is the pancytopenia. For the pancytopenia production defect, the aplastic anemia. First one is the aplastic anemia, or the most common one is the aplastic anemia, where tissue is not having sufficient amount of production precursors. Why? The bone marrow is replaced by fat tissue or fibrous tissue. Bone marrow is going to be having the fibrous or fat tissue. Because of that, the production area is going to be reduced. That is the aplastic anemia. Other than that, bone marrow replacement by metastasis. The cancer where cancer which has been developed in a separate place come and look inside the bone marrow and develop inside the bone marrow. Because of that, the cell production is going to decrease, right? Then fibrosis. Fibrous tissues are going to be developed, which may be lead to aplastic anemia. Destruction of cells within the bone marrow, named as ineffective erythropoiesis, right? Cells are going to be produced, but produced cells are going to be destroyed inside the bone marrow. Maybe due to immune condition, maybe due to some kind of misidentification of cells by the same owner's body, right? Destruction, ineffective erythropoiesis. Immune condition, which I have mentioned earlier, likewise, immune condition where red cells are going to be destroyed by the own antibody. Peripheral destruction also can be caused the pancytopenia, right? When the blood cells come out to in this time, it is going to be single cytopenia, not the pancytopenia actually. Sometimes some immune condition attack to the red cell. Sometimes some cells are going to be attacked to the white cells. Sometimes some cells are going to be attacked to the platelet. One is the SLE, systemic lupus erythematosus, where the nuclear anti-nuclear antibodies are going to be developed. They are going to be destroy the nucleated cells. The last one is hypersplenism, where the patient is having a big spleen, or the spleen is the pooling agent of the blood cells. The produced cells are going to be pooled in the spleen. If the spleen is going to be get bigger, what is going to be happen? Their pooling area is going to be get bigger. Because of that, produced cells are going to be get pooled inside the spleen. The circulating cells are going to be get low. Maybe lead to nomocytic non-chromic anemia, right? Then we come on to the aplastic anemia. It is the presence of peripheral pancytopenia. Definitely, it should be a peripheral pancytopenia with marrow hypercellular, in which normal hematopoietic tissue are replaced by fat cells. I told you, normal hematopoietic cells are going to be replaced by fat cells. No abnormal cells, right? Out of 3, 2 things has to be complete to diagnose it as a pancytopenia. The HB should be less than 10. Absolute neutrophil count should be less than 1.5. Platelet count should be less than 10. So 50. If 2 of these are going to be get okay, we diagnose the patient as aplastic anemia. Patient HB should be less than 10. Neutrophil absolute count should be less than 100, less than 1.5 into 10 to the power 9. The last one is platelet count is less than 50. Right? There are T types, right? See, these are the 2 normal marrows in the A and B. But once you come on the C there, here it is going to be fully packed with fat tissues. The cell production area is going to be diminished. When it comes to this one also, not much, but somewhat extent, the fat tissues are going to be developed. Because of that, we can classify aplastic anemia into 3 categories. See here, almost all the bone marrow is going to be replaced by fat tissue. This one also same. 3 stage according to the severity: very severe, severe, and non-severe, right? Severe, very severe, and non-severe. The classification of or the identification should be done according to this one. So what we can do in severe condition, neutrophil count is less than 0.5. Again, 500 volt order. In very severe, it is going to be less than 200. In severe one, platelet count is less than 20. Very severe one also same one. If you observe the retic count in both one, it is going to be less than 0.5. But when it comes on to the non-severe one, it is almost same as the basic clue of the diagnosis of aplastic anemia. Neutrophil count is less than 1,200. Platelet count is less than 10. And retic count is less than 1.0. Right? So aplastic anemia diagnostic clue is there, but for the confirmation, you have to do the bone marrow aspiration and observe the bone marrow, you can see hypocellular bone marrow. Hypocellular bone marrow we can see. But in these conditions, blood pictures show normocytic normochromic cells. Right? Normocytic normochromic cells, but red cell distribution is going to be right. Distribution of cells are going to be very much. I am not talking about the RDW. The cells distribution is going to be, we can see here and there red cells are going to be, they are going to be normal in number and stuff. Okay, that will end up my things. Any question?
In G6PD deficiency, what would be the blood picture?
Dhanushka, in which condition?
G6PD.
Yes, in G6PD, if you observe the blood picture, right, that is which I have not mentioned. It is showing the it is going to be show the dimorphic blood film. It can see the normocytic normochromic cells, as well as very good phenomenon we can see where the bright cells and blister cells, where half of the cells or the fragmented cells, one part of the cells can be break down by the cells. The phenomenon actually, if I think it is better if I have time to describe it to you if you are interested, but the time is the factor which I
Yes,
cannot,
I know that. You just
right?
touch those
So,
areas. Yeah.
all right. So, where it is going to be bite by the spleen, due to that, bite cells and blister cells can be seen in the G6PD deficiency blood. That
Even Haynes body.
and also Hans body. Hans body also can be demonstrated by supraviolet stain.
I thank you.
Right. Okay. If you don't have question, Bogura, shall we wind up? Okay, then thank you for listening and best of luck.